So the TB research agenda really needs to align with what are the global priorities, and they fall broadly into doing four things. So it's around knowing your epidemic, knowing your response. It's about developing new tools, specifically around new diagnostics, drugs, and vaccines. The initial, in terms of addressing the delivery of, or improving delivery of our current interventions, is required to optimize the impact of our current interventions. Focusing on developing new tools is what is required to help us end the TB epidemic. Without new tools, that won't be possible.
So, one has to look at what are the reasons underlying missing cases. There are complex and many different types of reasons. A lot of it is to do with who has got TB, where are they sitting, how easy is it to get to a clinic, how long does it take to get a test result, can you be put onto therapy immediately. So we've got problems at many points of the pathway in which we are losing people. I certainly feel that if we have point of care diagnostics, meaning that if an individual can be readily identified as having tuberculosis quickly and then placed onto effective therapy, and that means two big asks. We need a good point of care diagnostic, and we need combinations of drugs that will be active against both drug sensitive and drug resistant TB. We can make a big impact. It's just difficult for people to access what they need to be diagnosed and then treated for TB. And so barriers must be brought down at all levels. Science, I think, has got a critical role to play. It's not only science, though. We've really got to look at the health services and the health systems as well.
And some of the people that are considered to be high risk of getting TB, the children, people living with HIV, people that have worked in the mines previously. So knowing who is at risk and having special programs to target those people is one way of diagnosing TB in the marginalized populations. Farm workers are also considered to be at high risk, so the health system has to be proactive in reaching those populations.
To step up, we as scientists will probably have to think very carefully about the level of investment and development that we are aiming for. Do we just want to have new treatments and diagnostics that work in a big city where you have all the resources you want? Or do we really need very simple tools that are easy to roll out into the periphery, into rural areas, into areas where there is no access to what we commonly think is necessary to do science? And for that, we will have to rethink a little bit our agenda. We will probably have to not develop things that we can publish in the best journals of this planet, but we will rather have to have our own African agenda to develop robust and relatively cost-effective things that the government can afford and can actually roll out all over the country. And this is perhaps a little bit less glamorous, but it will be very helpful for the people out there that need these new tools.
Scientists need to find more effective strategies to improve detection of tuberculosis amongst patients that present with symptoms of TB. I think that we have an excellent screening algorithm for TB that enables patients to be triaged into diagnostic tests if they're coming into facilities. The problem is twofold. We need better implementation science research to enable more effective implementation of the algorithm so that every symptomatic patient can be linked to a laboratory test, and every positive laboratory test is linked to a patient initiating treatment.
So the tests that we use to diagnose TB are in the main are laboratory-based tests. So what we need to do is to either get those tests out to the rural area, and the Gene Expert is a very nice little test that can be conducted in a single unit, so it can be conducted at outlying clinics, or we need to get a system that we can get specimens back into the laboratory and get them tested as quick as possible. The gene expert will give you the answer within 2 hours as to whether you have TB or not, and whether that TB is resistant to rifampicin, our most important TB drug. So it's just improving access to diagnostic services.
The National Department of Health has there's been created something called the TB Think Tank, and this is a group of scientists who are advising the National Department of Health on strategies, and one of the strategies they're advising the Department of Health on is on how to find the missing cases. There's one task team headed by Dr. Nazir Ismail from the NICD, and Nazir is chairing this task team, and they're identifying strategies to find the missing cases. These include optimized screening approaches, enhanced contact tracing for TB index cases, enhanced case detection amongst key populations and vulnerable populations, and also improving diagnostic algorithms and tools, and improving quality standards for recording and reporting.
So as a vaccine researcher and a tuberculosis vaccine researcher, there's no doubt in my mind that our focus should be on prevention. I don't believe that we will be able to treat our way out of the tuberculosis epidemic, and that's because so many patients are infectious and transmitting tuberculosis to others before they are diagnosed and treated. So I believe our focus should be on development of an effective and safe new vaccine that protects children and adults and HIV infected and uninfected people against developing tuberculosis disease.
So to combat TB, we really need a multitude of approaches. And it probably starts with a proper vaccine that protects effectively, not just extensive disease, disseminated disease as the current BCG vaccine does, but protects well into adult life and protects against all forms of tuberculosis. So prevention would be a great addition in our current armament against this pathogen. Thereafter, early diagnosis would be very important. At the moment, we are missing a lot of cases. We are taking a very long time to diagnose active tuberculosis. And we are losing a lot of people who actually already have a sample submitted that shows a positive growth for TB because of this long process and because of the difficulty that patients have in accessing effective diagnostic services.
We're particularly passive about the way we try to solve the TB epidemic because we expect people to themselves turn up at clinics when they feel ill so that they can get diagnosed. And I think this is certainly one thing that we can address. We need to be more proactive, go out into communities, go out into TB hotspots, and also try and seek out people who appear to be healthy but may actually have TB. And so this is certainly something that we are trying to actively work on.
Missing TB cases is a major problem globally and in South Africa. Out of the estimated over 10 million cases in 2016, almost 40% of cases were undiagnosed or unreported. And the question is, where are these missing cases and how do we get on top of this problem? So I think the first thing is, where are these missing cases? And they're found in congregate settings like prisons. We're also missing cases in our healthcare facilities like hospitals and clinics. Lots of people attend hospitals and clinics for reasons other than suspicion of TB. But the bulk of the missing cases, I feel, are found in the community. They're living in the community, and particularly in the peri-urban areas, and particularly the informal settlements, the slums and the shanty towns. That's where these missing cases are found. And the next question is, how do we find the missing cases? Until recently, we didn't have very good tools to find the missing cases. Now we have molecular tools like Gene Expert Ultra. We have the urine LAM tests, which works well in certain subpopulations, for example, advanced HIV. So there are some tools now that we can leverage to find these missing cases. What do we do? So one way to target missing cases is to go into congregate settings or TB hotspots like prisons and screen everyone who enters these facilities. We have right under our noses many people who attend our healthcare facilities, our hospitals and our clinics, and many people pass through with undiagnosed TB. So we need to target those cases. And then, of course, we need to change the whole paradigm about how we think about case finding. At the moment, we passively find cases, means patients come to the clinics when they have symptoms. We need to take these new tools out into the community. If we keep doing things the way we always did, we're going to get the same results.
So to step up our response requires additional resources, commitment and effort. And in terms of resources, we clearly need more money to do all of this. But we can't, even if we get more money, unless we have more people that are skilled and are committed to doing the research, we're not going to go anywhere. And TB, like the history of TB, TB has been around for centuries. Some of our tools, the microscope that we still use to diagnose TB in many parts of the world, the vaccine, the BCG vaccine, both of those are more than 100 years old. And the people doing the research are also old. We need to re-energize the TB research field. We desperately need new investigators to come and take over from us and take up the battle cry and help us develop these new tools. So it's a wonderful opportunity for early stage investigators, new people to come meet with those that are experienced researchers, find out what the opportunities are and to get involved. And we are committed to supporting the development of new people coming in. So the time is now. Don't wait. Come join us.